Hi, my name is Dina Birkenhauer, and I am actually an educator at Hospice of Cincinnati. But the reason I'm here today is because we're going to talk about Molst. Is anybody familiar with Molst? Yeah, some of you guys. I know some of you guys have gone through the training. It actually stands for Medical Orders for Life-Sustaining Treatment, and we're going to talk about situations where it would be a very useful document. So let's kind of think about this do not resuscitate scenario. So a 72-year-old male calls 911 with weakness. The EMS crew gets there, they put him on oxygen, and they get his vital signs. His pulse is 172, his respirations are 18, and his blood pressure is 90/62. That pulse is pretty fast, right? You really want it to be somewhere between 60 and 80. The respirations are okay. The blood pressure is a little low, but it's not critical, and it's probably low because that pulse is so rapid. His skin's slightly pale, he's awake and oriented but anxious. I'm going to hazard a guess, if I had a pulse rate of 172, I'm going to be feeling a little bit anxious myself. He's placed on a cardiac monitor, which shows that he's in ventricular tachycardia. If you don't know what that is a rhythm that's not very sustainable, meaning that after a very short time period, it's going to go into ventricular fibrillation, and then the patient's going to go into asystole, which means that they're basically, they passed away, and something has to be done if you're going to try to bring him back. He is wearing a state DNR bracelet. So he's not in cardiac arrest, right, because his heart's still beating, albeit fast. He's not in respiratory arrest. He's alert and oriented. So he tells the EMS that he's a DNR. So what are his treatment options at this time? What can they do for him?
Try to get it under control.
How would they try to get it under control? What are some things, some actual hands-on interventions that they could try to do? They can't see you guys on the video, just yell it out. It's okay. It's okay. What'd you say? I'm sorry? They could try some Ativan, some other medications, right?
Put him on O2.
They could put him on oxygen, perfect. They could put him on a cardiac monitor. Are they going to take him to the hospital? Absolutely, they're going to have to take him to the hospital. So they could do some cardiac medications. They could do some synchronized cardioversion where they actually would shock him while he was awake, and that is not any more fun than it sounds. They would transfer him to the hospital emergency department with probable admission, continue his oxygen. But here's the question we don't know the answer to. Does the patient want all of that? We don't know. And that's where Molst comes into play, Medical Orders for Life-Sustaining Treatment. So it comes into play when the patient starts to decline, but they haven't gone into a cardiac or respiratory arrest. So it gives directions for what to do in that time span. It's actually based on the Molst paradigm, which we are so creative. That just stands for Physician Orders for Life-Sustaining Treatment. So the only thing is Molst was initiated in La Crosse, Wisconsin in 1977. Physician Orders for Life-Sustaining Treatment basically just means that in La Crosse, Wisconsin, only physicians can sign this set of medical orders. In Ohio, because we call it Molst, it can be signed by physicians, nurse practitioners with prescriptive authority, and then also physician assistants. So that's the difference. The paradigm is the same, it's just who can sign these orders. Research studies have been done to demonstrate that the paradigm is not only effective in determining what the patient wants, but also what they receive. And if you guys are interested in looking it up, there is a Molst website at www.molst.org that you can look at. So let's look at the first research study. The name of the study is A Comparison of Methods to Communicate Treatment Preferences in Nursing Facilities, Traditional Practices versus the Physician Orders for Life-Sustaining Treatment program. Okay, short title, succinct, real easy to find, right? So, if in all seriousness, we're going to talk about 2 research studies today. If you're actually interested in reading the studies in their whole, you can find them on that Molst website, or you can reach out to me through Kelly and I can email them to you, okay? So what this study actually did is it evaluated the effectiveness of Molst compared to traditional advanced care planning. A lot of places for their advanced care planning, they fill out the DNR form, right? That everybody completely understands everything about because it's so easy to work. Yeah. It's a very confusing form. It doesn't make a lot of sense. So they do that, and then physicians will also just write medical orders on a standard order sheet, right? So that's what they compared, was the Molst document compared to just that traditional way of doing advanced care planning. They looked back at data, that's what retrospective means, between June 2006 and April 2007, And they basically did this with stratified random sampling from 90 long-term care facilities through Oregon, Wisconsin, and West Virginia. And they looked at 1,711 resident charts. So they really looked at a pretty significant number. What they found through this study was that residents who had POLST forms were more likely to have orders about life-sustaining treatment preferences beyond CPR than residents without. When we do the full 8-hour Molst training, we talk a little bit more about what those numbers were. So just to kind of give you a perspective, patients with POLST orders had that time period that I was talking about with that gentleman in the DNR scenario. That was addressed like 95% of the time with patients with POLST forms. With just traditional practices, it was addressed like 6.2% of the time. It was a huge difference. Don't hold me to those percentages, but it was that huge of a difference. There were no differences between residents with or without POLST forms regarding symptom assessment or management. Because what do we always hear from patients? If I don't want treatment or if I'm a no-code, that means what? I'm not going to get any care, right? We know that's not true, but that's a misunderstanding in the community. And then those with POLST forms indicating orders for comfort measures only were less likely to receive medical interventions like going to the hospital than those residents with full treatment orders, do not resuscitate, or those with full code orders. So basically what that means is the POLST is a set of physician orders, and it really helped guide that care in that critical time period. And when they looked at this, the patients who wanted only comfort measures, only 2 of them ended up going to the hospital, and 1 of them had to go to the hospital because they fractured a hip. You know, you need pain management for that. And they don't really discuss why the other one went. So out of like 400 patients, or I'm sorry, out of the 1,171 patients, that's what they found. So the use of the POLST program offers significant advantages over traditional methods to communicate treatment preferences in the nursing facility setting. So here's the second study, a comparative retrospective observational study of the prevalence, availability, and specificity of advanced care plans in a county that implemented an advanced care planning microsystem. Isn't that fun? I just like reading that for some reason. It just makes me happy. I have no idea why. So the objective is to just find out if the outcomes for patients changed over time when they put this managed systematic approach into place, i.e. the POLST. Did the POLST really make a difference? So they looked at data back from 1995, 96. They started the program in 97, and then they looked at the data from 2007 and 2008. So they gave the program a full 10 years before they looked at the data. They did this in all healthcare organizations throughout La Crosse, Wisconsin, and what they found were that 540 adults died in 95, 96, and 400 died in 07 and 08. Now, if you guys are into research, you know that we can't control how many people die in a time frame, right? You can only look at what you have. So let's look at how this worked. So in 95 and 96, they had 540 patients die, and out of that number, 85% of them had advanced directives when they died. That's pretty high, don't you think? I mean, I don't know that our community is that high, so their community, their culture was already doing pretty well. However, they still increased it with the POLST paradigm to 95.2%, or 437 patients. I'm sorry, I apologize. In 07 and 08, that actually went up to 90%, or 360 patients out of 400 had advanced directives, okay? In 05 and 06, out of that 459 who had advanced directives, 437, or 95.2%, had them in their charts when they died. Wouldn't you guys love to see advanced directives in patients' charts when they pass away? They even increased that number to 99.4, or 358 out of 400 patients 10 years after they started this program. So look at that. Out of 360 patients who had advanced directives, only 2 of them didn't have them in the charts. That's pretty outstanding. Those who had DPOAs, or healthcare power of attorneys, before they started this program was only 77%. They were able to increase that to 90%. And then whether or not the treatment was consistent with the patient preferences, it was 98% before the program, and they still increased it to 99.5% again. So that's pretty impressive. So what the overall findings suggest that a high prevalence of advanced care plans can be achieved. They can be specific enough to assist with clinical decisions and achieve a high rate of compliance between what the patient actually chose for their end-of-life care wishes. So where are we at with Molst and surrounding states? So this is where I get really just transparent with you guys and tell you that in the state of Ohio, Molst has not passed legislation yet. Okay, and I say yet because it's actually going to the lame duck session here this month in the Ohio State Congress and representatives and whatever they do at that legal point, okay? There's a 50% chance it's going to pass, which apparently is a great chance for lame duck sessions. So after I say all that, let me also reassure you that there is nothing in Ohio state law that prevents us from using the Molst document. Not passing legislation, all that means is that if a physician chooses not to follow these orders, the patient doesn't have any legal recourse for them not following the orders. But there is nothing that says we can't use these as a medical set of orders, and that's what we're doing in our community right now. That's what we're moving forward to. In West Virginia, their legislation actually passed in 2002, and they even did a revision of their program in their form in 2012. One thing that they have in their state is an e-directive state registry. So if you live anywhere in the state, you go to any healthcare facility in the state, they can actually pull up your living will, your advanced directives, your Molst document on an e-state registry. I would love to see Ohio be able to get to that. I think that would be excellent. Pennsylvania, their State Department of Health actually has endorsed it, and they have a standardized form that you can access. So why it hasn't passed legislation there, it has become their state protocol. It's what they do in their state. Indiana, they signed it into law in May 2013, and then in July 2013, it became legally valid throughout the state. Michigan is actually doing a pilot program across 8 counties in Traverse City, Michigan. It ends in July 21st, 2015. And again, it has been recommended by the Michigan Commission of End of Life. So there's really a lot of belief that that's going to pass as well. And then in Kentucky, it passed the Kentucky House legislation in March 2014, and it's still, as far as I'm aware, I can't find any updates on Kentucky, it's still sitting in the Senate waiting for a vote, because our legislative system moves so quickly, right? So my point in bringing all these states surrounding Ohio is just to let you know that it's going to pass, okay? And task forces are really encouraging communities throughout the state to start a pilot program, to start making this the protocol in your communities. It didn't pass legislation in La Crosse, Wisconsin until 15 years after La Crosse was making this a very successful program. So again, there's nothing that says we can't use it. It needs to become our protocol like it is in Pennsylvania. When it does pass, it will replace the current DNR form, but it's never going to be meant to replace the living will or healthcare power of attorney. Okay, I'm going to be 47 next month, and I have a living will and healthcare power of attorney. I don't have a Molst document, and we're going to talk about why I don't as we get into this a little bit further. So living wills and healthcare power of attorneys are still very prevalent for people, okay? It's just a certain subset of patients that are going to be appropriate for the Molst conversation and document, and you guys have a lot of those patients here, and we'll talk about that in a minute. So, where is Molst at in Cincinnati? Linda Briggs from Respecting Choices in La Crosse, Wisconsin came here and trained facilitator and facilitator trainers in January of 11. And I am one of the original facilitator trainers from 2011. And I'm going to be real honest with you, the program just kind of stuck there for that entire year. We really didn't do a whole lot with it. Towards the end of that year, we did hold a training session for some individuals. And then starting in 2012, I started going out and doing a lot more education. We started holding more facilitating training classes. And actually, Senior Link and PACE began a pilot project in January of 2012. Now that makes me very sad because now, as you all know, Senior Link is closed. So they are no more. But they had a very successful program going there. Christ Hospital has started some pilot projects throughout several of their outpatient clinics as well as their palliative care department. I just did a Molst facilitator training just a week ago, and they're actually starting one in their cardiac outpatient clinic now. So they're actually really moving forward with that. Maple Knoll has started pilot projects in their ECF, and they were going to have all the conversations with the Bodman Center patients by the end of 2013. My understanding was that they were still working on that throughout this year, but that they are still continuing to have these conversations. Several other ECFs have started pilot programs. Hyde Park Healthcare Center is actually up and running with their program. They've got it all set out. They do it routinely during their care conferences. Melanie Crozier, who's their director of nursing there, is also one of our facilitator trainers, and she's willing to be a contact for any other ECFs that want to start a program in their facility to kind of help iron out those, red tape and those logistical bugs. So she's a great resource. I've talked to so many ECFs.
Okay.
This kind of a presentation, we're just a 1 hour Molst overview to let you guys know what's going on, what's coming down the pike out there. So it's really starting to gain steam. What really pushed it along though was the Hospice of Cincinnati grant, which was in 2013. Yeah, spring of 2013. And that's the name of it there, Transforming Conversations, a Provider and Community Model for Improving the Quality of End-of-Life Care. And what that did is it focused on these topics right here. So they're working with primary care physician offices to teach physicians how to have end-of-life conversations with their patients. Shocker, right? Shocker, really, and I'm sure this isn't a surprise to you guys. There was a study done a few years back that demonstrated that the longer a physician knew their patient, the worse they were at predicting how much time they had left to live at the end of their life. And guess what? They're human. They get bonds with their patients. There's that interaction, that emotional bond. So they aren't always the best predictor. And they're not trained how to have these conversations in their education because they're trained to fix and heal and cure. And so this is out of their comfort zone, and they have done a fabulous job of stepping up and really wanting to do this. They're working on technology and epic enhancements through the grant, and that's another thing that they're working on. They're starting with TriHealth because that's kind of where the grant funneled through, and then the plan is to take it out to other organizations once they work the bugs out. Then there's also the advanced care planning facilitators, and that's my part in this. That's what we do. We hold monthly advanced care planning facilitator training. A couple of you have already attended that, and it's an 8-hour session where we help you learn the skills on how to have the conversation, which is what supports this forum. And then there's also the community engagement, which is conversations of a lifetime. And if you Google that, it's a great tool for you to even use with your own families and friends on how to have that conversation at end of life. Another thing that's happened just this past late summer, fall, is the Health Council, in collaboration with the ACP Collaborative, they're doing like a pilot project that lasts until, I believe it's the end of May or June. And what they're doing is ECFs have grouped up with hospitals. For like example, Hyde Park Healthcare Center is like partnered with Christ. And so they'll actually follow those patients that have had the conversation as they go into the hospital and back to the ECF to track how well the form's being honored and how well those wishes are being communicated. So there's multiple ECFs in that and multiple hospitals in that as well.
Dina, we're actually with Christ also.
You guys are with Christ also? Fabulous. Did you guys already know that? Okay. Everybody know that? No? Okay.
It's in the very early stages.
It's in the very early stages. So you're going to be here. I guess that's probably part of the reason I'm here then, is to let you kind of know what that's really about. So it's a pretty cool, ACP Collaborative is a great project to move forward, and it fits really well with the HOC grant. So I've been talking a lot about the Molst discussion. So what is the Molst discussion? Who qualifies for the discussion? The best thing about this form to me is it's not just a form. It's a set of medical physician orders, and it also is based on a conversation. Because how many times do you guys take that DNR and you go into a patient's room and you say, okay, do you want to be a do not resuscitate? And they look at you and they have, I don't know, sure, yes, no, they don't know what to say. There's no conversation, there's no informed discussion going on. And that's what really is behind this document, and that's what makes this document so successful. So the Molst discussion involves the patient. It involves a durable healthcare power of attorney. And the reason they're bolded is because, and to color different, is because those are the people that you really have to have in that room. Because guess what? When the patient can't speak for themselves, the healthcare power of attorney speaks for them, right? But if the healthcare power of attorney doesn't know what they want, how are they going to know what to speak for them? I always rat myself out. When I did my healthcare power of attorney the first time, I put my husband first, and we'd had lots of conversations, okay? I put my best friend second. And I'm driving down the road from work one day, which I shouldn't be talking on the phone, right? And I'm talking to my girlfriend, and we're talking about Girl Scouts and my kids and her kids. And I say, oh yeah, by the way, you're my healthcare power of attorney. And she goes, okay. And so we go back, and now we're talking about other things. She called me a little while later, a couple days later or something, and said, hey Dina, what does that mean? You know, and what do you want? And I was like, oh yeah, we probably should have had that conversation. So since then, I've changed it to my husband first and my kids second, and now my kids know what we want because they're of age. But even I didn't think about that. I was just filling out the blanks, filling in the box, check marking everything off my list, and didn't think about what I needed to do. Other caregivers can be a part of the conversation, and there's nothing wrong with that, but I have a personal word of caution for that. If you've got 10 family members and the one patient, what does the patient usually end up doing when you start asking these kind of questions? They look to the caregivers, right? They look to the family members and they start getting engaged. What they want is based on what they could think their family wants. And that's what we don't want to happen. You want it to be what the patient wants, and that's what the conversation is based on. The discussion is based on CPR wishes and medical interventions. Those are highlighted in a different color because those are the two most critical things that you want to discuss. You want to discuss all of them. Antibiotic use. Artificial nutrition and hydration is huge for ECFs, right? Because it comes to that a lot. So I'm not saying that those things aren't important. They are, but those things aren't emergent. You know, nobody's going to call a physician at 2 o'clock in the morning and say, Mrs. Jones, I think needs a tube feeding and we need to get it in now, right? You're not going to do that. But you are going to call the physician and say, Mrs. Jones' O2 sat just dropped to 82%. We're going to follow her Molst orders. Just wanted to let you know, kind of a thing. So that's why those two are highlighted. Okay, I'm going to show you a little video here. And this is an example of a physician having a do not resuscitate conversation based on the document with a woman and her significant other.
I've been on a medical appointment for a patient in her late 60s who has been diagnosed with chronic obstructive pulmonary disease, or COPD. The patient is joined by her partner and is being seen in her physician's office. During the conversation about treatments that are available, the patient initially wants everything done to keep her alive. The physician explores the patient's goals and values, and upon learning about the realistic outcomes and burdens of various treatments, the patient chooses to limit certain treatments on her pulse rate.
Susan, you've been really sick since the last time you were in the office.
Yes.
So what happened?
I had pneumonia.
And I understand from looking at the hospital records that you were back on a ventilator, back on a breathing machine again.
Yes.
So you've tolerated the breathing machine 2-3 times now that when you've gotten sick before. How was it this time?
Not good.
Just didn't like how it made you feel.
She was really uncomfortable this time.
Took a lot out of you too. Now that you're home, tell me a little bit about, how is your life different? What are you able to do? What are you not able to do? How are you getting along? Are you able to do pretty much what you need to for yourself?
No, I really have to do a lot of the care for her. Help her get bathed and from room to room and so forth.
How far can you walk now without having to stop to catch your breath?
Not that far.
Mm-hmm. So that's a significant difference from what it was before you went into the hospital, isn't it?
Yes.
We know that with this type of disease, and I think you know it already, that you'll have episodes where you have infections, you will continue to get a little bit more short of breath, be able to do less for yourself. That's the tough part of this disease.
Yes, it's very difficult.
Mm-hmm. I was looking at your chart, and I'm kind of surprised to see that you don't have an advanced medical directive. Do you know what that is?
Yes. Yes, we do. Yes. Yes, we're aware. We just haven't gotten around to it. No, we haven't.
Mm-hmm. Well, an advanced healthcare directive would give you an opportunity to choose Ginny, or maybe someone else, if you would choose, to make medical decisions for you if you were so sick you were unable to make them yourself. So one of the things that I'm hoping to happen here is, yes, we'll sign this advanced directive form, but I hope it stimulates some discussion between the two of you, how much intervention that you want. Okay? So this is a form, and I'm going to give it to you, and I think you guys need to spend some time discussing it. Okay?
We will.
So tell me a little bit about what you want as you look forward. If there's a crisis that comes tomorrow, do you want to have CPR?
Yes.
Okay.
Definitely.
Okay. And comfort is important to you as well, isn't it? Okay. So let me talk to you a little bit about CPR. You know, CPR is done when someone has no pulse and has stopped breathing. So if I ask you whether you want CPR, it's not really a fair question, because it doesn't put it in the context of how sick do you need to be to require CPR. Especially with a woman with an advanced illness like yours. If you stop breathing, if your pulse stops, your chances of having a significant recovery after CPR is low, really low. And the quality of what life you might have, should you be lucky enough to survive, would be unlikely to be very good. So you probably watch CPR performed when you see characters on television pushing on your chest, maybe a bag over your mouth with some oxygen and air being pumped into your lungs. Is that something that you would want?
No. No, it's not.
So,
We want all her wishes.
so for sure, we want to make sure that you're comfortable. We want to make sure everybody's comfortable, regardless of what kind of decision they make. Okay?
Yes.
But now that we've talked about that a little bit, there's another form that we should talk about called a Molst form. And I don't know if
What's
you've
that?
heard of that. Molst stands for Physician's Orders for Life-Sustaining Treatment. So this is a way of taking your wishes, putting them down on paper. I would sign it, you would sign it, and that becomes the order to physicians in the future about how much or how little to do as you become sicker. Okay?
Well, if we have an advanced health directive, do we have to have that before we fill the Molst form?
Well, you don't need to have an advanced directive. I think that it's great in the sense that you've already appointed, you know, Jenny to make decisions for you, and that will be the same name that appears on the Molst form. I think that that is convenient, but the Molst form can be filled out without having to have an advanced medical directive, but I think both are important. So let's go through this pink form. Section A is about cardiopulmonary resuscitation, and we've sort of had that discussion now. And I think I'm pretty clear from what you're telling me that you don't want to have any attempt at resuscitation in that way. Is that right? So I'm going to go ahead and mark that part as no. Now the next part goes through medical interventions and sort of talks about how much you would want us to do that if you become sicker. Okay? So I think I'm fairly clear from our discussion that one of the choices is.
Okay, I'm just gonna stop it there because I just wanted to focus on the DNR part. Any questions or comments about the video? So can you kind of see how he was given her information individualized to her? And that's what the goals of Molst is. You want to provide timely opportunities for informed end-of-life treatment decisions. And to break that statement out, timely opportunities. Do you remember when I said before, I'm 47, I don't need a Molst document? That's because I'm not at the end of my life at this point, or at least I hope not. So basically, you look at the patient and you look at them, serious life-limiting illnesses, terminal illness, advanced frailty. So you ask yourself that question, would I be surprised if this patient died in the next 12 months? If the answer is no, those are the patients that we're looking at to have this Molst discussion with. Okay, because typically those are the patients that have chronic illnesses, they're in and out of the hospital, you know, that we get them like they're like to here, and then they get a little worse, and we get them back even, then they get worse, and we get them back even. They never really come back up to their original baseline. So those are the folks. So that's that timely opportunity, informed end-of-life treatment decisions. I swear as I'm getting older, I really understand the saying, show your age. Is anybody old enough to remember chemical codes in the hospitals? Do you guys ever hear of that? When I used to work at the hospital, I worked on a cardiac unit, a telemetry unit, and we used to do something called chemical codes. So what would happen is a patient's heart would stop or their breathing would stop. All these people would go flying into the room with lidocaine, atropine, epinephrine, whatever they needed. They would start shoving it into the patient's vein, okay? The family would have to leave the whole 9 yards. But we weren't allowed to do CPR and we weren't allowed to intubate them. So what happened to all that medicine I'm shoving in the vein if I can't do CPR? It sits there, right? It goes nowhere. But nobody told the family that. Nobody explained that to them. So we were kicking the family out so they weren't with the patient when the patient died, and we knew that it really wasn't going to do any good. But it was let the family feel like they were doing something, but it wasn't an informed treatment decision. We weren't, if we had told them, you know, the reality of it is just those medications without CPR, they're not going to do anything because they're not going to go through the system. How many of those patients would have chose straight out do not resuscitate? Some. How many of them would have chosen full code? Some, right? But they would have at least had the entire information to make those decisions. Like I said, it's not a one-size-fits-all discussion. It has to be individualized to the patient's goals, values, stage of health, and readiness. I always tell the story of my mom at this point because she had asked me years ago, it's been 5 or 6, 8 years, I don't even know anymore, if I would be her healthcare power of attorney. So I asked her what she wanted, and she told me she wanted everything for as long as possible. Well, based on my beliefs and my conscience and what I knew I could do, I had to decline. And she was not happy with me. I mean, I'm not going to lie to you about it. She was not happy with me. But I had to make sure that I would be able, as her healthcare power of attorney, to stand up for what she wanted. I would never question anybody else's decisions for her, if that's what she chose, but I couldn't make them myself. Her goal at that time and value was that she wanted to live as long as she could. Fast forward a few years, and my grandmother ends up in the hospital for the 3rd time in 4 weeks, dementia, urinary tract infection. We see it all the time, right? Every time she lives at home, every time she goes to the hospital, she's crying, she's trying to get out of bed, they're tying her down, they get her better for 2 or 3 days, they send her home, we're right back in again. My mom called me one day because this was torture to her. Watching this experience changed.
The kids are on their way, okay? We'll be here in a few minutes.
Watching these experiences changed her goals and values, and she asked if my grandmother could be signed into hospice. We signed her into hospice. She died 2 months later, peaceful. But my point is her experiences changed her readiness and her goals and values, and that experience changed then what she wanted for her end-of-life care as well. So it requires presenting options and discussing potential outcomes of decisions. I'm a patient, I tell you, I know I've been in the hospital 3 times with COPD, I still want that ventilator. Okay, so we discussed that. Do you understand that if you have the ventilator for 7 to 14 days, they may need to put a trach in? Is that something that you're willing to do? Is that an outcome that you're willing to accept? Well, no, nobody ever told me that. So it's having those discussions, letting them know what potential could happen. Providing directions for providing or foregoing aggressive treatment. And it requires advanced care planning facilitation skills. You don't just come in with the form and say, do you want this, do you want this, do you want this? You have to be able to have those skills to be able to pull out what it means to them to live well, what their goals are, what their values are. We're facilitating the conversation, so we're helping them determine what they want for their end-of-life care and not telling them what's appropriate. And that's the best thing about this form is that they say to you, I don't care if I've been on the vent 4 times in the past 4 weeks. That's what I want. Even though you may not agree with that on a personal level, that is their choice. They have been given the information, and as healthcare professionals, we will support that. Sorry about that. So again, we're exploring those goals and values based on their medical condition, complications, past experiences, and also concept of what it means to live well. I jokingly tell my husband that when we get older, all he's going to need is a beer and a football game, right? He's a happy guy. Me, I need to physically move. I don't do well just sitting around. I get antsy. I need to be physical. So we've had a lot of discussions how I'm probably going to end up in the ECF because I'm going to drive him crazy, and that's fine. That's fine. So again, you want to support and validate that patient as they make informed treatment decisions. And make referrals if you need to. This conversation was meant to be held in the design of the paradigm by nurses, social workers, and chaplains. But we hear a lot of kickbacks from chaplains and social workers that they don't feel comfortable with the clinical aspect of it. Okay, and I get that. So maybe they're going to help that patient come up with a list of questions for the physician. As a nurse with a cardiac background, I'm not going to feel comfortable talking about dialysis and renal disease, right? But I know enough that I can help them come up with a list of questions to take to their physician. Okay, the next video we're going to watch is from Rock Center. I don't know if anybody's seen this, with Brian Williams. It's a great video about La Crosse, Wisconsin, and kind of pulls everything together. Yeah, right there.
Our next report here is one of those things a lot of American families should see, because it's about a moment in life all families face. Tonight you'll see something remarkable going on at a hospital in Wisconsin that has developed a humane and life-affirming way to face what we all eventually face, and that is the end of life. Just as remarkable, as you'll see, are the families who allowed Harry Smith to join them in the conversation.
People come to the emergency room to have their lives saved.
Resuscitation complete. Good.
But as Americans live longer and longer, the emergency room is not the best place to begin a conversation about how you want to live the rest of your life, or even how you want to die.
Do you know where you are?
Tough choices about which treatments and how much treatment become a guessing game, often powered by guilt. Palliative care specialist Carrie Lapham.
One family member may say, no, we need to do this. We have to, we have to do everything. And another family member that is saying, we just have to make her comfortable.
But that disagreement rarely happens in what might just be the best place to die in America, La Crosse, Wisconsin, home to Gunderson Lutheran Hospital. Here, an astounding 96% of the patients have a game plan for life and death. It's called an advance directive. It starts with a very tough, very honest meeting they call Next Steps.
Tell me what you know about Paul's condition.
He's not going to get better. And we know that.
Paul, what do you hope for with your current plan of care?
Give me as much time as I can get. But keep me comfortable.
Paul and Jean Pearson have been married 21 years, a second marriage for both. Together, they have 6 children. He's a 73-year-old retired architect. She was an interior designer. This is what real love and devotion looks like.
If you were having a good day, what would that day be like?
I'd probably be fishing.
You'd be fishing.
And she'd be with me. She's more important to me than anything.
Paul Pearson has inoperable lung cancer. He and Jean don't want there to be any doubt about how he wants to live out the rest of his life.
This discussion.
So in this meeting, run by Jackie Cartman, a nurse practitioner, Paul and Jean faced their decisions and fears head on. We were there to witness the process, which is as emotional as it is profound.
Paul, what worries you about your illness? What fears do you have?
Breathing is going to be a problem. And probably having to go to the nursing home.
And what about going to a nursing home?
It's being stuck there. I don't want to be a burden to her.
Paul is emphatic. He doesn't want to linger or suffer, and he is not afraid to say so by refusing treatment.
What I'm going to do now is read through these situations. If I have a serious complication from my cancer or treatment for my cancer, so that I was facing a prolonged hospital stay and my chance of living through the complication was low. For example, only 5 out of 100 patients would live.
I would deny treatment.
It was expected that I would never either walk or talk or both, and I would require 24-hour nursing care.
And it'll be the same answer.
It was expected that I would never know who I was or who I was with.
Same thing.
And I'm in agreement with.
Looking ahead to the end of life is a journey that takes no small amount of courage. And what happens in this meeting is as important for Jean as it is for Paul.
And the thought of losing him terrifies me. This is really a gift that you're giving to your family. Because at some point, if they're needing to make a decision, they can go back to this and say, yes, this is hard, this is difficult, but this is what mom or this is what dad really wanted. Take a deep breath on it.
One of the things they've learned here is all this talking about how you want to die, in many cases, helps people live longer, and incredibly enough, costs less. At Gunderson, patients in the last 6 months of life spent half as many days in the hospital as the national average. But Hammis has a PhD in philosophy from Notre Dame. He led the Gunderson team that came up with this better way to die.
When we talk with patients who are getting sicker over time, and they tell us, I've reached a point where I know there isn't much more, I'd like you to keep me comfortable. The cost of care goes down because we're not taking them back to the hospital and doing all these expensive things they don't want.
Some people will see this, though, and say, it looks like they're trying to talk people out of care.
That's not the philosophy. We really want to understand the patient's perspective. We want to understand the patient's values.
Okay.
And planning ahead has another benefit, peace. When it's time to go, there is little rancor or remorse.
Hello, Eva.
While we were at Gunderson, we met the Foot family. Just the week before, 94-year-old Eva Foot was at a local fair.
I know that what you wanted for her is for her to be comfortable.
But severe stomach pain brought her to the emergency room. Eva had a life-threatening blood clot in her intestine. The Foots, like so many others here, had an advance directive, which meant they had a roadmap which led them to forego surgery, because doctors found Eva's chances of regaining anything close to her former health were next to none.
Your parents let you know ahead of time what they wanted to do.
Yes. Knowing ahead of time, it takes a load off the family.
2 days later, Eva passed away peacefully, her wishes honored. For Paul Pearson's children, the plan was tough to take at first, but now that they know what he wants, they have accepted it.
You know, it does put everybody at ease.
To know that there is this plan in place.
Yeah, it really does. All of us can be prepared for each step as it comes.
The Pearsons don't feel like victims of their circumstances. In fact, just the opposite. The process has helped Paul decide how he wants to live the rest of his life. On the schedule, more fishing and historical reenactments. Jean and Paul have been going for years, and now is not the time to stop.
How helpful is it to have these conversations, to go through the scenarios ahead of time?
This gives us that advantage that we don't have to be second guessing. What should I do? We've already made those decisions. And they're hard decisions. But we're okay with them.
Our thanks to Harry Smith, but also to Paul and
Isn't that a lovely video?